Thanks, Darshak. And now I'll open to questions from the committee. I'll just start on this end. Kit?
Both excellent presentations. I'm curious, and just going back to Dr. Bateman's graph before, showing the sort of fuzzy math of days supply, and whether you have considered, instead of doing 50 MMEs in a 7-day supply, why not making it like something like just a global MME threshold? And obviously there's some issues with that, but is that a consideration, and what are the pros and cons of doing that?
Yeah, that's it. So the question for those, hopefully everybody could hear that. Yeah, that's a really interesting approach to think about it. What I'm just wondering is, sort of, does that obviate the fuzzy math issues to some extent, or does it just substitute one set of problems for another? I don't know the answer to that, but certainly that's an approach that could be considered.
In the data you showed when there were some like hard limits on opioid prescribing, do you have any data or any ability to look at response to that measure, to that method, like patient satisfaction or pain scores or any outcome measures? Yeah, it's a great question. So one of the nice things about working for a commercial insurer is that you're responsive to your clients or employers or Medicare Advantage individual plans or others. People will leave you if they don't like you. Same with if you're the PBM that's servicing these individuals, they can go to a different PBM supplier. So those types of measures are very, we don't look at necessarily a simple measure like that, but these are really complex business decisions and negotiations that are made. So one thing I'll say is that even though they're not captured in patient satisfaction, there is clearly a very strong interest in making sure that the people that are served or their representatives are satisfied. Having said that, there were direct phone dial discussions that were held with pharmacists and others that were actually faced with patients at the point of care to look at this. And the metric that we chose to look at was, did the patient choose to pay out of pocket? For example, the way the hard edit works is it only works if you want to use your insurance coverage. At that point of sale, a patient could say, you know what, forget it, I'm just going to pay out of pocket, I'm not going to use my insurance. So they could do that, and many opioids are actually, for some individuals, are not that expensive, so it's not a massive financial barrier. We found that that rate of going outside that was actually extremely low in a large telephone example survey that we did. I can't remember the exact numbers, I'm going to guess here, but it was comfortably under 5%. And that pharmacy conversation was felt to be appropriate. So we tried to look at that. We didn't look at pain scores. That's very difficult to look at, but that's what we looked at.
Jen?
Thanks for your fantastic talks. My question is for Dr. Haberman. So in one of the last graphs that you showed where there was low and standard and high prescribing, it's kind of a two-part question. How did you conceptualize which procedures should or should not fall within those buckets from a procedure standpoint? And relatedly, how did you all conceptualize how to classify procedures together in groups?
Sure. So those are two different questions. So the first one, for the chart I showed with low, medium, or low, standard, or high prescribing, that comes from our surgical outcomes program prescribing guidelines, which was the supplement in our 2018 Annals of Surgery paper, where we offer 3 potential doses for each procedure. So for a Whipple, for Whipple procedure, there would be a low dose option, a standard dose, or a high dose. And so that's what that chart referred to, is of those 3 options, where are prescribers prescribing? And then overall for Department of Surgery procedures, it's about 20% prescribing at the low dose, which is often just NSAIDs or acetaminophen. Standard dose was about 40%, and then I think about 25% were prescribing at the highest dose option. As far as grouping the procedures together into the different tiers, like we showed for the orthopedic procedures, that was really based upon both our surgeon champion and our multiple stakeholders' input into what types of procedures could be considered most similar to each other as far as pain goes. We also looked at historical prescribing, historical pain scores, and other factors. Length of stay, the longer the length of stay, the more likely they will know what to prescribe by the end, and so on. And so that was the approach we took with many of our surgical specialties. And the main reason we did that was so that we didn't give 25 options of 25 different numbers that surgeons would need to remember. We thought it would be best to give a few numbers, tier 1, tier 2, tier 3, or tier 4.
Thanks.
So I have a couple of questions for Dr. Sangavi. So the first is just on, the problem with these, or an issue with some of these quality measures is just this issue of benchmarking. So how do you know what the right, how do you know whether a group has gotten to the optimal percentage? And part of this is case mix, right? If you're a specialty clinic that does a lot of chronic pain, your percentage is likely to be a lot different than a place that doesn't. And how do you, the way these measures work is people try to drive the numbers lower. And how do you know when to stop? And how do you know what the right number is? So that's always a problem from a kind of evaluation standpoint. So first, just wondering if you can comment on that.
Yeah, so benchmarking is always something that's an area of debate, and I'll say a couple of things. The first is that the devil's in the details of how one uses the measures. So we did not share these or mail these to everybody or make them available. This was used to drive high-level decision-making at the national policy level for our organization, and then to sort of show this data to a number of people with whom we work to say, look, this is what we can do for you. Do you think this makes sense? That's the first thing I'll say. The second is that what we also focused on was a measure of compliance. And our theory was that degree of variation indicated that there's substantial opportunity for improvement. So we didn't say that you have to go to 0. But CDC compliance for initial guideline prescription probably, I think we can charitably say that if you're 50% of your prescriptions or less are being written outside those guidelines, and remember, these are people that are opioid naive, that's just bad practice. I don't think there's a justification that can be made that your patients are sicker or you're in an area where opioids are more effective than other areas. That was sort of the position that we took as we were making these decisions. I think your point is a good one. And I think that it has to be balanced with needing to actually do something in the face of a national crisis. So that was sort of this was a very difficult and controversial sort of set of discussions that our organization had, but that was sort of the texture of how we thought about it.
Can I follow up?
Yeah.
Another question? Thanks. So I've actually seen the analysis on initial provider contact and how that impacts utilization rates, essentially. And at that conference, which was also a NASM conference, actually, for a different workshop, we asked, did you adjust this data? And the answer was essentially no, we didn't adjust for, And so the problem, of course, looking at these analyses is that you're always concerned of the confounding and the fact that maybe people who go see a chiropractor first are just not as sick. And so I guess my concern is, first making decisions based on, those types of analyses and the fact that a lot of this stuff seems to be internal and not subject to peer review and publication and all that stuff. And just wondering if you could comment on that.
Yeah, great questions. Well. I'll say a couple of things. So that's a different issue. I'll say that your criticism about things being done internally is a really good one. So we actually put everything out for peer review, but it's a very challenging process. Particularly, it's an enormous amount of work to put things through peer review for organizations that are not used to it. So I'd argue that there should be a mechanism by which that kind of information can be made broadly available, which also could be sort of possible and not go through that. That's a separate comment. Having said that, though, with the I'd say that, again, the devil's in the details. The reason we did that study was because we had a theory that we should reduce barriers for individuals to access non-invasive forms of care, PT, chiropractic. It was not to limit care. It was not to stigmatize patients. It wasn't to pay anesthesiologists less money. It was simply the idea was, would it make sense for us to remove that barrier? So that was a very focused sort of question we asked. And when it looked like there was a dose response and substantially lower utilization of opioids. In our study, by the way, we did adjust for demographics, Elixhauser score, age, type of insurance, income to the extent we could, ethnicity, geography. We thought that that was evidence that we should then change benefit design. But I think your broader point of sort of doing not risk adjusting and that driving potentially harmful decision making is one we can all learn from.
So thank you both of you for two very interesting presentations. Can you get rid of that? I know this recording.
There might be too many on.
Okay, we got it.
There's one on next to you on your right.
So I have sort of a narrow question for Dr. Sangavi. We looked, I'm Hillary Cunning's New York City Health Department, population health, population of 8.5 million. So appreciate sort of the challenge of scale that you all see in health systems, but certainly at a national insurance program. So one question, we looked, and I just want to kind of ask you how you accounted. This is a little bit on follow-up of Roger's question. We looked at, we're a state with New York state legislation requiring for a first prescription that it be written for no more than 7 days. Using PMP data, we examined the impact of that legislative, the enactment of the legislation, and found actually a secular trend of decreasing prescription that existed prior to actually implementation of that legislation. And so the issue around confounders and secular trends becomes very important, I would sort of offer, in really understanding the impact of things like hard stops, which I know can be very challenging for patients and as well as clinicians. So I'm just to follow on that, to look at your data from that, or have you looked at the data from that point of view of what's happening either concomitantly at different regional locations, and whether, to what extent it changes are explained by those factors?
Yeah, it's a great question as well. So I didn't show all that data here. We have data that looks at, as I said, there was a number of organizations that were affected by the edits and others that were not. And what we saw was that dramatic change from 50 to 90% within a month. We thought that that was fairly strong evidence that there wasn't a secular trend leading to that degree of change. I think if we had seen a smaller degree of impact, your question absolutely makes sense. Our comparison group, by the way, we also had looked at, we did not see those trends. So that was the best extent we could look at it with. But I think, again, should always keep in mind that secular trends in the background, as you said, New York, Massachusetts, others states are legislating in the background to explain those that happen over longer periods of time. Certainly a good point.
And second question for both of you, which is, Dr. Sangavi, you essentially challenged the committee to perhaps consider approaches that are beyond sort of what we were, our assignment, which is to recommend to the FDA around what conditions ought to be prioritized for clinical practice guidelines. So I infer, and I kind of wanted to hear from both of you, I infer from your comments is there ought not be condition-specific clinical practice guidelines. And furthermore, that just the existence of those guidelines is insufficient, although based on your sort of continuing to go back to the CDC guidelines, the foundational part is actually the existence of a guideline, but nonetheless should be across conditions. Dr. Haberman, I think what struck me about your presentation at a health system or health systems level is that you were able, sort of in a stakeholder engaged way, to create guidelines across conditions, specific to conditions / specialties. And I would just like to hear both of you kind of speak to each other a little bit and to us about that tension and whether, in your experience, Dr. Haberman, this kind of a cross-condition approach would be satisfying to the different specialties and the different parts of the health system you're working with.
Oh boy. Okay, so first, I believe we need condition-specific guidelines. And I think we need to separate the non-surgical acute pain from the surgical acute pain, and then separate within those two groups as well. I can speak from within the health system with these hard 3 or 7 day limits that have been imposed either by insurers, by state legislatures, or by retail pharmacies, that it's very frustrating to certain surgical providers or specialties with high pain procedures. On the other hand, these limits are way too high for many surgical procedures that patients can take 0 opioids and be treated with NSAIDs or acetaminophen. And if we stick to the 3 or 7 day limit, and surgeons also don't think in days, which we've kind of talked about, at least the surgeons I work with, they don't like the day thing, doesn't make sense to them, and it's easy to game. I think it can result in overprescription of opioids for conditions that do not need any.
Yeah, I hope that the way I presented did not indicate that condition-specific guidelines have no place. I think they're complementary. So I think that they can work in conjunction. So I think, as Elizabeth pointed out, the 7 days of 50 to 90 MMEs is still a lot of opioids. So I think what we've put into place is at least some accountability across an entire insured massive population. Even within that, there's going to be significant practice variation. So certainly engaging clinicians and having specific guidelines there makes sense. My critique, though, is that the amount of effort to I'm a pediatric cardiologist, and many of you are clinicians as well. We have limited bandwidth to do QI approaches and give a massive amount of attention. And so this is a complex rollout. To have specific guidelines for every subspecialty within a clinical system, that's going to be built into an EHR, or I just think about what is the implementation plan for this to be scaled, and not only one institution, but many of them. That is a lot of time, money, and effort. I would just submit, is that the best way? This is competing against other national priorities for what are really, really important things these clinicians should be doing. Does this rise to that level if we institute the hard limits? Does that protect us? Because even with all this compliance and guidelines, I would argue that one of the critical problems is that individuals with opioid use disorder are not being identified and connected with evidence-based treatment. Our enterprise is now seeing that as the major challenge and not necessarily spending a huge amount of time on supply limits. You may disagree with that. I just think that's the conversation to be had, is that there's a budget of time and attention from clinicians. Is this how you want to spend it?
For each of you, actually. So for Dr. Haberman, it seems like you've really focused on post-surgical, and you just alluded to doing this for non-surgical, but it sounds like you haven't really done it yet. And we talked earlier about some of the, challenges, in terms of increased kind of diversity of presentation, and I would say probably less predictability. I can have a patient with 10 out of 10 back pain or somebody with 2 out of 10 back pain. It's very, the presentation and how long the pain's been present, stuff like that. It's all quite different. And I'm just wondering if there has been attempts or thoughts about trying to address the non-surgical stuff. I really haven't even seen much literature on opioid prescribing, amounts and use and stuff for non-surgical conditions at all. And just wondering if that's a place where you guys are going, and if there's any issues that you see there.
So at Mayo Clinic, we have an enterprise-wide opioid stewardship oversight group. And within that group, I chair the acute prescribing subgroup. So the acute non-surgical pain falls under that. But we have mostly focused on emergency department prescribing and not other non-surgical prescribing. Within the emergency department, our champions there felt that the 3-day limit was generally appropriate for most patients, the 3-day limit for the CDC. They did decrease opioids or eliminate opioid prescribing for many conditions, and then feel the 3 days is appropriate for others. So that sorted itself out, but where we have not addressed this issue has been on the inpatient wards and for non-surgical acute pain there. And I don't mean to use this as an excuse, but we've been all consumed by our change to the new electronic medical record. And so there's things that we had to table for a year, but that we hope to pick up this year as well.
Another question for Dr. Sangavi. Just, you know, the CDC, I mean, I was on the steering committee for the CDC guideline. We did the evidence review, and I wrote the editorial, or was one of the authors on that editorial you put up. And I wonder if you've gotten pushback. I mean, the editorial is about don't overinterpret and don't apply the guideline to people, you know, who it wasn't meant to apply to. And you know, there is one recommendation on acute pain, but all the other recommendations really are chronic pain. I think that you can extrapolate, but that's not what the guideline does. And I wonder if you've gotten pushback on that, number one. And number two, there are guidelines on acute pain prescribing. I mean, you can go to the ER and, you know, sites and things like that, and they've got guidelines on acute pain. So I wonder why you decided to kind of extrapolate, adapt the CDC guideline rather than, you know, doing one that was, you know, formally developed for acute pain.
It's a good question. So let me ask you, which guideline would you have suggested we use at national scale in 2017?
I mean, I don't know when the ER guidelines came out, but I think that there are
that was
some,
just ER. So
yeah,
we needed
yeah.
a national solution. So I didn't mean to be impertinent, but I'm saying that was the best evidence that was available at the time. And regardless of whether some individuals on the committee felt it was only for individuals with long-term acute pain, other members of the committee felt that they were drafting guidelines for initial prescriptions. So we had to make a decision, just as we do in clinical medicine, based on the best available data at the time. That was the one we chose for that reason. I don't know, maybe there was another one, but we felt that, again, a national guideline endorsed by CDC, for which a letter had been sent to all practicing clinicians, if we were going to choose one that we were going to have to defend, would have been the easiest one to defend. I hope we made the right decision.
So first I want to thank both our presenters for really thoughtful and very helpful presentations. I wanted to ask a broader question about guidelines and the patients who are exceptions to the guideline. So that we talked this morning about individualization of care of patients with pain, and although most or even the vast majority of patients are covered either by your institutional guidelines or your national scale guidelines, what about the patients that fall outside that, who are still having pain when the initial opioid prescription runs out? Have you, in either Mayo or Dr. Sangavi in your work, looked at barriers to those patients getting access to reevaluation, and whether there's a gap between when their initial prescription's running out but they still have severe pain and when they're able to either be reevaluated and they may or may not be need opioids, or to actually have a refill if it's indicated?
So our guidelines include the length of time the surgical prescribers should be prescribing for their surgical patients. And if I'm recalling correctly, it's 6 weeks for all surgical specialties other than orthopedics, which requested it to be 12 weeks. After that, the prescribing should be directly handed off to, or by then, the prescribing should be directly handed off to another provider. This is something that's of great interest at Mayo Clinic because we have a large destination surgical population, and the handoff is actually better for patients returning home than it is to our own local patients who are going to a provider down the hall. This is something we are actively working on. We're starting with spine patients right now and doing qualitative and quantitative work about these prescribing handoffs. I will say pain medicine is very interested in this topic, but they're not large enough for the volume of chronic opioid users we have as surgical patients. So I think this is a very important topic.
Yeah, that's a really thoughtful question, and I think you're challenging at least the research community to understand what the predictors are potentially of those individuals that may require that enhanced level of personalized care. I mean, one of the things I really was struck by with Elizabeth's data was looking at the significant variation. I mean, if nothing else, looking at which conditions lead to the greatest amount of opioid use sort of already defines at least a group of surgical procedures, for example, that are at the highest risk of pain, for which some individuals may break those sort of hard guidelines. So I think what I hope happens is that the foundational research that's done here then is done in a way that has a line of sight to, well, what is the intervention that would be recommended as a result of that? So one could, say that for these particular procedures, we should have telephone-based or other pain evaluation follow-up immediately, either by telemedicine or in person within 5 to 7 days, to anticipate when pain is not being well controlled could be one approach. I'm sure there are many others that also could be suggested once we identify these, but that's a really great question.
If I could I just follow up? You started your presentation by talking about the problem of devising a measurement framework, and it's sort of almost a truism that if you can't measure it, you don't know what the appropriate response is. So I guess the follow-on question would be, do you think you have a pretty good measurement or a measurement in progress of access, timely access to care for patients who continue to have severe pain when their default opioid prescription is expiring?
Right, so great. So I'll say for those of you that'll have access to the slides, we did develop those, we had a measure. And the one we chose, and I don't know if this is the best one, so I think I'm trying to be really honest, that there's a degree of uncertainty, and we did the best we could with limited information. But on a claims-based measure, we looked at a small group of our guess at the highest risk surgeries for long-term pain. We chose 5 or 6 procedures, and then we looked specifically at whether there was a re-prescription for opioids that occurred outside that frame, whether there's an emergency room or inpatient visit where a diagnosis of pain was listed in one of the primary positions. So we tried to create a composite. That measure actually improved over time. So at least on some level, we didn't see a dramatic shift there, but your challenge I'm still cognizant of, which is that doesn't mean that every individual was served as the best way they could. So I think we really would depend on the type of research that will come out of the work here to help refine our approaches.
Just one, very quickly, I just want to comment that we can look at patients with chronic pain, but in health services research, we're looking at patients who are able to access that care. And I think that's a true challenge. So we can look at patients with these diagnoses or continued opioid refills, but we're possibly missing those that are not getting the access to which your question was referring.